I'd like to talk about adjuvant therapy for kidney cancer. I like the topic. I like the topic a lot because it's a great space for multidisciplinary care, right? This is where we have ineffective surgery, incompletely effective surgery, I should say, and incompletely effective systemic therapy. This is the sort of spot where they both come together, right? Because if we've done effective surgery, we don't need adjuvant therapy. The problem is, how do you pick that out? How do you know who to put on those trials, and are those trials working? So some of what I'm going to talk about is a little bit translational, and some of what I'm going to talk about is sort of clinical trials in practice. So I'm going to start with an observation that I made yesterday to the residents. When I was speaking to the residents, I said, if I were to think of my job, I would say that my biggest job isn't to comfort or heal, it's to manage healthcare risk. And I tell my faculty that all the time. That's our job, manage healthcare risk. Somebody comes to you with a problem, and you've got to figure out what's the best way to manage the problem, and it may or may not be an adjuvant clinical trial, it may or may not be surgery. You've got to figure that out. And so we all seek to predict and understand and prevent future healthcare events. That's what we're trying to do. Someone comes to you and they really want to know what's going to happen to me, and how are you going to prevent that from happening to me? In the case of kidney cancer, after surgery, what they're asking is, am I going to have a recurrence? And can you lower that risk, right? Can you make it less? Put me on an adjuvant medication and make that risk of recurrence less. And so I sort of have this picture here, which I showed you. We're trying to predict when a localized tumor will become metastatic, when a metastatic tumor will lead to cancer-specific deaths. And if this looks very simple, I was told I can't walk away. I don't know if anybody's out there listening. They are. Okay, so I won't walk away, although I like to usually walk. Really what they're asking is, if you look at that little sort of timeline there are a number of endpoints within that timeline. And those endpoints the FDA really pays a lot of attention to, right? Overall survival, cancer-specific survival, metastasis-free survival, progression-free survival. It's really a very deceptively simple timeline. But when the FDA starts to think about a drug, a medication in the adjuvant setting, they have to start to ask, what's your primary endpoint? And you may know, and I'll show you about the S-TRAC trial, that S-TRAC was able to prevent progression or delay progression, but not improve overall survival. Was that a meaningful endpoint? The FDA had to ask the question. I was down there 3 months ago, and they were asking sort of outside advisors, should we think of PFS as an important endpoint? And that's something, when you sit in front of a patient, that has a lot of practical implications, right? Recently, apalutamide, based on the Spartan data in prostate cancer, was approved by the FDA for MFS, metastatic-free survival, in castrate-resistant prostate cancer, right? But it's not overall survival, the holy grail. So I'm sort of trying to weave into the notion that in all these trials, we've got the obligation to understand them in the context of how you communicate it with the patient, right? So that's what we're trying to do. That's what we're trying to do. So in this space, that's the adjuvant space. And there's lots of translational science around that. Biomarkers, clinical models, right? The neoadjuvant spaces before that. And so as physicians, as managers of risk, here's what I think my job is when I go to work every day. I have to identify who's at risk. So inherent in that, whether it's prostate cancer or kidney cancer, we're talking about screening and population studies and public health in cancer, right? And big data, right? Then I've got to use risk tools, biomarkers, predictive models, genomics to say you're going to get cancer, you're going to have a recurrence. Then I've got to communicate that risk to the person and give it to them in a way they can digest it and make sense of it. And then finally, I've got to try to mitigate the risk. We spend most of our time, and the way we mostly think of our jobs, is trying to mitigate risk. Do an operation to decrease the risk of recurrence. Do an operation to decrease the risk of death, right? Give chemotherapy to decrease the risk of recurrence. And once you've done all that, and I've had this conversation a bit yesterday with the residents, you start at the beginning, right? I've cured the patient, now I've got to screen patients for recurrence, right? So that's how I sort of see it. Now, I'm going to go through a couple of very quick studies. I don't expect you to sort of, go. We're not going to go into depth. But here's the state of kidney cancer screening. Recently, a GWAS study, genetic variants associated long telomere length, are associated with higher risk, increased risks of developing kidney cancer. This is in peripheral blood lymphocytes. This is the group from the NCI. And so you sort of read this in European Urology, and you see all these sort of fancy statistics and the forest plots, and they say we have a system, a biomarker, if you will, to predict who's going to get kidney cancer. Okay, maybe it works, requires validation. Then you start to see, and there's lots of new data like this. You see it in the journals all the time. Another GWAS study looking at risk loci for developing kidney cancer. Right? This is who's going to develop kidney cancer. This is that first risk step, screening. Right? And in the end, people publish lists and lists of biomarkers in clear cell carcinoma, right? Molecular biomarkers, clinical biomarkers, et cetera, right? There's comprehensive, TCGA data looking at gain and loss, chromosomal gain and loss, looking at heat maps, having epigenomic markers. I don't expect that you're going to sort of, know these things, but they're out there. And really what they're asking is, can we predict who's going to get cancer, whose cancer is going to recur in kidney cancer? And they look at the mRNA level, the microRNA level, the transcriptome level, the metabolome level. They put them into aggregated sort of models of risk. If you've got expression of this microRNA, if you've got expression of that metabolome, you're likely to recur. They do it in papillary cancer, right? And so it's easy to sort of lose a sense of the big picture when you read these things. But what they're really trying to ask is, can you predict who's going to get the disease and who's going to recur? And do we have a biomarker? And you see them all the time. Here's a group from Memorial. And the same candidate genes come up: VHL, PBRM1, SED2, BAP1, right? The same things keep coming up again and again, right? And they put them into, here's a group that looks at metabolomics. We actually have done a study, I'll show you, where we actually test patients' serum amino acids. And we found that in 190 patients and 104 controls, 15 of 26 amino acids were altered in levels of patients with kidney cancer. And maybe this is a metabolic disease. And we put it into linear regression, and we do ROC analysis and area under the curve, and it looks like it works. But in the end, and we've got gain and loss, CMA, cytogenetics, c-MYC loss. But in the end, I'm gonna stop here for a minute. I just went through a whole litany of translational data. I'm going to ask one of the residents. Maybe I'll ask Jen. When a patient's sitting in front of you, and they're sitting after their nephrectomy, and they had, a clear cell kidney cancer, what's the most useful way to tell them what their risks are? I've just given you a bunch of biomarkers. When you have that conversation, what do you rely on most? Yeah, I'm sorry. Maybe I got your name wrong. Sorry.
So stage of the tumor, fungal pathology, the type of histology is the variants of variants or prognostic features. Margin status, node status,
all those things, right? And then you're expected to take that data, package it up, interpret it, and spit out a number for them, so that they have something actionable, right? It's exceptionally boring, but the truth of the matter is, no matter what solid cancer we manage right now, the clinical biomarkers in kidney cancer, breast cancer, prostate cancer, etc., wind up right now, remain stage, grade, and histology. That's it. Stage, grade, and histology. All the biomarkers in the world right now, getting validated, looking good. Right now, the way you face a patient is you look at stage, grade, and histology. And that is exceptionally boring and exceptionally mundane and often not exceptionally helpful. And so what happens? We package those up.
We even have a pathologist. Make them feel really good.
So in clinic, what we do is we package it up. And so we create nomograms, right? Models. We got the UISS model for kidney cancer, the MSK model for kidney cancer, the SIGN score, the Liebowitz score, the Krakowitz score, right? We have all these models that are Kaplan-Meier estimates, and they're nomograms, and they're internally validated, and they're externally validated, right? And they suggest that you've got some level of discrimination where you can actually predict future events, right? And if you look at all these models, if you take them all and you unfold them and you look deeper into them, here's what they use. They use stage, grade, and type. They use tumor size, performance status. They use presentation, age, gender, and coagulative necrosis. All of those models that are being used currently to predict recurrence and the basis of clinical trials use that. Easily measured, easily sort of annotated clinical tools. All right? And so what happens is all of these models are retrospective, and only 2 of them actually have only localized disease. Most of those models, when you look deep in those models, and I have, most of those models have a lot of metastatic patients in them, right? So we think we've done a good job using these models of being able to predict localized recurrence, when in fact most of these models really have metastatic disease in them. And so here's the number of patients that have localized disease in the models that are currently used. In the Memorial model, I found 72 patients with localized disease. In the Leibovich model, 479 patients with localized disease. And in the UISS model, the first model that came out to predict recurrence after kidney cancer, 14. And I couldn't find in Krakowitz's or the Science Score the number of localized patients. Add those together, 565 patients that are N0, M0, that these models predict who's going to recur. Now, I just told you that we've got these evolving biomarker landscape, right? But in the end, and I've been involved with the sort of creation of a lot of clinical trials, they always fall back, and the same probably could be said in bladder cancer, and the same could be said in many types of cancer. They fall back to these models. And we've had teleconference after teleconference saying, who's eligible for this trial? Who's eligible for that? How do you figure out the eligibility? And these are the best data we have to figure out eligibility, right? That's pretty, that's pretty sobering, right? Because we sometimes don't see that. What we usually see is, the Leibovich model, right? Everybody uses that model, or UASS. But in the end, it's got real significant limitations. The ability to predict risk has significant limitations. So, when you look at the models and you externally validate the models, right? The external validation C index is poor. So let me see. Is Matt Ho here? Matt, when you have a C index of 0.5, what does that mean?
There's a 50% correlation between the outcome of the test, the outcome of the model, and real life.
So essentially, it's no better than the flip of a coin. Right? So when you externally validate these models, your C index is poor. Right? Right? So why is that so important? One, because we use them to tell patients whether they should go on trial or what their risks are. We think these models help us to predict. When in point of fact, the external validation is poor. And yet, I've spent countless number of hours debating at various forums how to use eligibility, right? The 7 most recent adjuvant kidney cancer trials are based on these predictive tools, which at their bare essence have 565 events, and to which we've accrued now almost 10,000 patients to those trials based on the recurrence patterns of 565 patients. Right? Why is that important? I'm going to talk to you about these 3 clinical trials. Anybody want to guess how much the ASSURE trial cost? Or the S-TRAC trial? Or the CTC's EMOTION trial? Now, I've asked the companies the numbers. They won't exactly give me the numbers. All right? But I'm going to tell you, best I could do based on some research and some website and conversations, this is how much it costs. Somewhere between $80 and $265 million. Right? Based on 565 events, our best guess. Now, you could argue, right, that's just where we are in 2018. That's as best as we have. You got to go with what you got, right? But I mean, what happens though, and it happens frequently in medicine, is that we keep going further and further and further and further away from the core. And the further you get, the more you could sort of, forget, what the data really are based on. It's sort of like, the whole mortgage crisis in the States, right? You sell crappy junk and you repackage it 5 times and it looks good, right? It's sort of like that. But when you're sitting across from a patient, if you don't think of that, you think you know more than you do, right? I went and did a little research. What will $265 million buy us? Because one trial costs $265 million. The University of Michigan, is a state-run institution. The School of Medicine, the budget, $82 million. The School of Law, $42 million. The School of Pharmacy, $15 million. The School of Public Health, $34 million. Nursing, Keep going. Dance gets a lot of money at the University of Michigan, $37 million. More than the school, twice as much as the School of Pharmacy, right? The School of Social Work, $22 million. Add it all up, and I came with $265 million. We have one trial, which I am on the steering committee of, and if they heard me say this, they probably wouldn't like it. My estimate is it's $265 million trial. Based on the outcomes of 565 patients, we used the Leibovitz criteria to design that trial, right? And if you add it all up, you can fund all those schools at the University of Michigan. I'm just doing this for comparative purposes and maybe for a little bit of a demagoguery, right? Ultimately, you don't know what you don't know, right? That's the problem. And if the further we get away from sort of believing that we're building on ourselves, you got to step back every once in a while. That's my point, right? So are the current models good enough to guide $300 million in expenditures? I'd say probably not. And in fact, what we did is we went back. I haven't published this yet. We went back using the Assure data. I was the urology PI on the Assure data. For those of you that don't know Assure, it was an adjuvant trial. I'll tell you about it in a minute. And we went back and we used the Assure data, and we went back and we looked at all those models, because all those models are retrospective, and all those validations are retrospective. So we used the Assure data to see if those models held up with prospective data, right? Data that we know is as good as we can do. And the C indices were low, right? It's even worse than what was. So whatever you read in the literature, I hate to say it, you got to look at it and squint your eyes a little bit and say, that's retrospective, that's this, that's that. But you don't think it's better than they report. You probably have to assume it's worse than they report, right? So my point is that when you're trying to figure out what the next steps are, the limitations of the data are pertinent and important. So how have we done with adjuvant therapies? I said before that adjuvant therapy for kidney cancer or anything else sits someplace between incompletely effective, albeit high-quality surgery. You can do really high-quality surgery, and that it's not going to cure the patient, and completely effective systemic therapy, which doesn't exist, right? If completely effective systemic therapy exists, what happens to surgery? It goes away, right? Why do you need surgery if you got you let somebody become metastatic and you give them the medication? It doesn't exist, right? But somewhere in between there is where adjuvant therapy comes from. And we've gone through the dark ages of adjuvant therapy in kidney cancer. We're sort of in the middle of the Middle Ages, if you will, and then we're getting to the Renaissance, which is immunotherapy, all right? So here's the dark ages. And I've listed just the most of them, right? Radiation versus observation for kidney cancer, that trial was done, right? Estrogen versus observation. They gave BCG for kidney cancer, right? Then a bunch of interferon trials. There was a nice German trial here that was a positive trial. It's the only positive. It was a tumor cell vaccine trial, but it had a lot of methodological problems. And it was published in Lancet, in the Lancet, and sort of it was summarily dismissed. Thalidomide, right? That was a recent trial. Chris Wood did that trial about 10 years ago. Thalidomide for kidney cancer. No benefit. Dark ages, no benefit, all right? Here's the Middle Ages. Incompletely effective surgery with more effective systemic therapy. And I'm going to go through these. The Assure trial, the ARISER trial, adjuvant G250. The Assure trial, adjuvant Sumitimib and sorafenib. The S-TRAC trial, adjuvant Sumitimib. The PROTECT trial, adjuvant Pazopanib. The SOURCE trial, right? This is like, I'm telling you, millions of dollars here. Adjuvant sorafenib, that's not been published. Adjuvant axitinib, adjuvant everolimus, right? So what happens is when you've got a drug approved, as we all know, in the metastatic setting, you just sort of start to move it earlier in the line. And if someone's willing to pay for it, you test it, right? And sometimes it works. But so far, strike out, except for one. There's a small signal here, which I'll tell you about. So adjuvant G250, I got involved with G250. This was an Ari Belderman, one of his first, his first forays. Maybe it wasn't, but it was an early foray into, pharmaceuticals. This was an adjuvant monoclonal antibody against CA9, and I was on the DMC, the Data Monitoring Committee, and we were trying to accrue to this trial, and we tried to pick the highest risk. There really was no guidance as to who you should put on this trial, so we picked the highest risk, and we couldn't accrue to the trial, so we had to back down the eligibility. And it was adjuvant IV monoclonal antibody versus placebo. It was a negative trial. Here's the no difference in PFS, no difference in OS. Negative trial. This company ultimately transitioned the compounds to an imaging compound, right? To try to identify using a PET scan. They use it to label clear cells, and it actually worked. We published a JCO article on this. Went down to the FDA with the company. Went to sort of the powers that be, and we wound up getting favorable ruling, but they didn't approve it unless we did another clinical trial, and then the company went bankrupt. So that's where that company went. Adjuvant Assure. This is sort of the ECOG trial. Adjuvant Sunitinib for a year, Sorafenib for a year, or placebo. Why a year? Because we didn't have any guidance as to how long it should be, right? Frankly, it's just like, why do you give 6 doses of BCG? Because that's what became the sort of the standard, right? So in that case, we had DFS and OS endpoints, and we published this, in Lancet. It was a negative trial. There was no difference in DFS and OS if you took 1 year of adjuvant sorafenib or sunitinib or placebo. There was no difference. Unfortunately, negative trial. And we looked at the clear cell subset because this was not only for clear cells, we also had some non-clear cells. No difference, all right? So then comes Adjuvant S-TRAC, right? This was actually sponsored by Pfizer, who also sponsored the Assure trial. They said, well, we'll be in the Assure trial with ECOG, but we're going to do our own trial as well, right? And this was a positive trial. So when you get a negative trial, you go into Lancet or JAMA Oncology or something, you get a positive trial, you go into the New England Journal, right? And so, about 2 or 3 months later, this got into the New England Journal. Adjuvant sunitinib versus placebo. They simply took a higher risk group, right? And they showed that there's improvement in disease-free survival, but no difference in overall survival. And the FDA sort of thought, should we approve this based on that information? And in fact, they did. And in fact, Sumitimib and Pfizer, if they haven't already been knocking on your doors, are going to start asking you whether you want to prescribe or use adjuvant sunitinib in patients with high-risk kidney cancer. Won't get funded. So the FDA has approved it. And so the conversation, though, in the States is going like this. What kind of discussion are you going to have with a patient who comes in after T3, venous involvement, negative margins, negative nodes, fits right into this? What kind of conversation do you have with that patient? I could give you 1 year's worth of a TKI, and you're not going to live any longer than if I didn't give it to you, right? And the patient goes like, what? But your scans will remain negative for longer. And they go, what? That's a hard thing for people to sort of understand, and it's a hard thing to communicate, right? Because some people think that what this really is just sort of delaying the onset of occult metastases, right? Now, frankly, you would think that as the data mature, that overall survival might get better. But if you look at those curves, on the right, it doesn't look like it's going to get much better, right? But it's approved and it's out there, certainly in the States, and you're going to have to figure out whether you're going to use it, and how you're going to describe it, and how you're going to do that, right? I'll also tell you that adjuvant sunitinib, sort of changes the clinical trials landscape, right? You get a drug approved like this, and suddenly, right, you've got to figure out, like, do I have to write that into my trial? Do I have to inform patients now that are on a trial that there is something out there that is approved, whereas before I didn't? And so everybody's got to sort of re-scramble, right, about how they're going to sort of present this to a patient because something is approved. Same thing probably with, the Spartan trial, recently published, New England Journal, ASCO GU, right? The Spartan trial, apalutamide, an AR receptor blocker, will delay metastasis in castrate-resistant prostate cancer. They didn't say it was going to make you live longer, but they do say that people who have got castrate-resistant prostate cancer who take placebo, on average, 16 months before they get metastatic disease. And if you took apalutamide, 42 months, right? Something like that. So you got to say to the patient, right, I could give you this medicine. It will delay the progression, but I'm not sure if it's going to help you to live any longer. Do you want to live with the side effects?
Magnitude, what's the median prolongation? It
Yes.
separates right at the fat part of the curve, but what is the median?
It's about the hazard ratio is 0.76. It's statistically significant, but it's
Hazard ratio with
it's like 0.4 or 0.2 or something like that. So inevitably you start to ask yourself, how come one trial is negative and with the same drug the other trial is positive? And there's differences. I'm not going to go through all the differences. Basically, the Assure trial had lower risk patients. The S-TRAC trial had higher risk patients. There was differences. And this is for clinical trialists in the arm, in the group. When I sit down with my fellows, right, I say to my fellows, it used to be that when you were a fellow in urological oncology, you could say, I want to be a prostate guy. I want to be a kidney guy. I want to be a bladder guy. But now, or gal, what you usually should say is, I want to be a clinical trialist, right? Or I want to be sort of a health sciences research guy or gal. I want to be sort of, sort of a delivery and operations, a systems, sort of industrial engineer type of, urological oncologist. I think that that's a better strategy than saying I want to be sort of a prostate guy. All right, so we went back and we looked at the ASSURE data, and we said if we used the S-TRAC criteria and we applied it to our ASSURE trial, do we see the same? And the answer is we didn't, right? And so, but it was an ad hoc retrospective analysis. It wasn't a planned analysis, so it's easy to dismiss it. But the truth is we cannot recapitulate those findings. And then comes PROTECT trial. Now the PROTECT trial, I'll tell you, since it's already been published, this is adjuvant pazopanib, right? Just another TKI, right? I was on the data safety monitoring board of this too, and as you saw the data coming in, you're thinking, this is going to be a positive trial, right? And what happened is they were giving everybody 800 milligrams. But because of hepatotoxicity, the protocol got amended, and it got amended to 600 milligrams, right? And it's an intention to treat analysis. So when they look at all of the patients, there's no difference, right? So it was a negative trial. But if you look at 600 versus 800, 800 actually looks like there was a signal, right? At least for DFS. But you can't do that. It was a negative trial. So this trial, even though there was sort of maybe something there, maybe the same things you saw with S-TRAC, it just was a negative trial, just by design, right? So when we sort of talk about clinical trials and clinical trials design and making those decisions, there are huge implications as you're going down that clinical trial where decisions have to be made, and they're very hard, all right? No difference in overall survival. So, just to summarize what I would call the Middle Ages of clinical trials, DFS and OS for ARISER, DFS for ASSURE, DFS for S-TRAC, DFS for PROTECT. And here's what Marty asked, right? What's the median DFS? If you are on the S-TRAC study and you take, the drug, you essentially save yourself roughly a year worth of, a metastatic, a negative scan. You have a negative scan for about a year. And the question then becomes, is that of enough value that someone's going to pay for it, right? A year of negative scan. All right, so that's the landscape of the clinical trials. Now I'm going to ask you a provocative question. To date, adjuvant TKIs in kidney cancer don't work well, right? That's what the data tell us. And now I'm going to try to explain to you why I think they don't work well, right? If that's true, why? And you might sort of say, well, it's not hard. We don't have a good enough agent. But you got to think a little bit deeper than that. And I'm going to sort of explain to you why not and now what. All right? So what I did is I asked one of my fellows, I said, go back and tell me what the adjuvant landscape looks like for all solid tumors. Because the breast surgeons, that's one of the things that I've got the privilege of. When I sit in M&M and conferences, I hear other people in other solid tumors talk about similar ideas, but they think about it differently, right? So the breast surgeons are convinced adjuvant therapy works, and the colorectal surgeons are sure adjuvant therapy is beneficial, right? So I said to him, let's just go back and look. So he looked, okay? And here's what he found. There are 5 studies that showed, as of a year ago, that their adjuvant therapies in breast cancer work, 2 in colorectal, 1 in GIST, and 2 in melanoma. The regimens I put here, all right? But here's what they say. The DFS, and by the way, there's only 1 approved adjuvant systemic therapy for GU cancer, and that's Sumitimib, right? As far as I know, that's the only one approved, right? But the DFS was between 2 and 11%. The disease-free survival benefit was only about 10%, and the overall survival benefit in the best of adjuvant studies was about 5%, and the cost, is as high as, for ipilimumab, $60,000, $70,000 a month, right? So you get, in the best of adjuvant studies in solid tumors, about a 5% OS and about a 10% DFS. And is that good enough? And why is adjuvant therapy simply not working in solid tumors? So 20,000 patients, 9 trials, 6 agents, overall DS 10%, overall OS 5%, a lot of cost. And you got to measure that against quality adjusted life years, and is it a value, et cetera, et cetera. And so why isn't it working? So I'm going to talk very briefly about timing and risk tools, all right? So the question I'm going to ask, is there any medical student in the room? Can I ask you a question? Are you taught about metastatic progression in medical school? Does anybody actually have a conversation with you about the development of metastatic disease, or is it just assumed at some point in one of your classes that, that metastatic progression occurs and we're supposed to understand how? Okay. So the presumption that we all have, the bias is that how does metastatic disease occur? The primary occurs, and the primary leads to nodal disease, and the nodal disease leads to metastatic disease. And there's this very nice stage 1 to stage 2 to stage 3 to stage 4 progression, right? We call that Halstedian kinetics, right? But do we know that? All of surgery is based on that assumption. When Halsted did a radical mastectomy, he did it because he thought taking off the breast not only would improve symptoms, but would prevent metastatic disease. And every time we take out a kidney or a prostate or a bladder, we presume we're going to prevent metastatic disease. Is that a safe assumption? This is Halsted, right? He essentially says that some tumors are slow growing. I'll call them a turtle. Some of them, as I talked to you yesterday, the residents about them, are hawks. But that clinical stage 1 goes to 2, goes to 3, goes to 4, and at some point circulating tumor cells occur, and at some point there's a billion of them, and you'll see them as a 1 centimeter nodule on a CAT scan, right? And if that's true, if Halstedian kinetics are true, then adjuvant therapy should work if you time it properly, right? But there's an alternative argument. And the alternative argument I first heard when I was a fellow, and I went to the AACR, the American Association of Cancer Research. I was standing in the back of the room, and I was with Peter Clark. He was a resident at the time. And Peter, I said, I got to go hear this talk. And I went to see this guy named Bernie Fisher. Anybody know who Bernie Fisher is? Right? Bernie Fisher is a breast surgeon, controversial breast surgeon at Pittsburgh. And Bernie Fisher had this notion that some cancers, he would say, are systemic from inception. They're born bad, right? Some cancers are just bad, right? And so this, if you don't think that this is, sort of a fundamentally important idea, I think you're misunderstanding. I get phone calls from lawyers across the U.S. all the time. And they say, I have a patient who had a 2 centimeter renal mass, and the doctor didn't tell them, and 3 months later they had metastatic disease. They missed it. And the reason that they're thinking is because it's Halstedian. If they only caught the tumor 3 months ago, this would never have happened, right? When in fact, maybe their tumor was, as I will say, Fisher-esque, right? You are systemic early, circulating tumor cells early. The mutations, the genetics, the epigenetics are so egregious, so early, that at the time the tumor starts and starts to grow locally, it's also capable of metastatic disease. In that case, adjuvant therapy is not going to work very well unless you time it differently, right? Much differently, unless you've got good biomarkers, right? Right? So, that's my point. I went back to the literature and I asked myself the question, can I prove how fast kidney cancers grow cellularly to see if they're more Fisher-esque or if they're more, Halstedian? This is the best I could find. This is a journal of Surgical Oncology on the growth of human malignant tumors. In order for you to see something on a CAT scan, it's got to be 1 centimeter, and that's about 1 billion cells, right? So these guys took a bunch of kidney cancer and kidney cancer cell lines, and they say, how long before I get 1 billion cells from one cell? Right? It's a logical question. It's a simple experiment, right? And they said doubling times this, and it winds up that the doubling times are somewhere between 66 days and 132 days. To get to 1 billion cells, you need 40 doubling times, right? So you're talking between 6 and 16 years, right? If you've got Halstedian kinetics, right? All right. So it means we've got to figure this out much sooner, right? Maybe we're giving them adjuvant therapy too late, right? So no good tools to time out adjuvant therapy, right? All right. So I told you about this. I told you about whether or not a kidney cancer, which is what you see on the left, that's a proximal convoluted, the putative, solid origin for most kidney cancers. Then you've got clear cell carcinoma, driver mutations, and then you've got secondary branch mutations causing metastatic. That would be the sort of, if you will, the genetic evolution of the Halstedian model. And then, alternatively, some patients may have this Fisher-esque model, right? Concurrently, really bad mutations, right? So, I'm not the first person to think of this, right? But anybody read The Gene or The Emperor of All Maladies by Mukherjee? Right? If you guys want to read a little bit of something interesting, he wrote this really nice thing, in the Annals of Medicine about a year ago. Cancer's invasive equation. And in this thing, I had sort of, had all these notions, but he sort of summarized them nicely. He said, think of cancer like an evolving ecosystem, right? Survival of the fittest. Some will be Halstedian, and some will be Fisher-esque. And he said, in the past, and he goes through the history, Paget did some nice autopsy studies in breast cancer patients. And he developed this malignant ink blot theory, this centrifugal theory of cancer, right? Cancer starts with a little stain, and then it spreads, right? So sort of like what we think of, right? This seed and soil technique, right? Why does the spleen never get a metastatic disease, but the liver does? Seed and soil. It sort of sounds like a little bit like evolution, right? There's this battle, if you will, this battle of, the survival of the fittest. Which branch, which tree, which genetic phylogenies are going to go down, right? All right? So it winds up that that's the story of tumor heterogeneity, right? And Marty knows this as well as anybody. And there's a ton of data coming out on tumor heterogeneity, right? So if you look at sort of mutational loads in patients with GU cancers, prostate has the fewest mutations as best as we can tell. Bladder has the most mutational load as best as we can tell. And kidneys somewhere in the middle. And then, so, all the way over, melanoma has a lot. Maybe that's why melanoma is responsive to immunotherapy more, because it's got a higher mutation, more antigens to present, right? Thoughtful. So I was talking to this with one of our scientists. At Fox Chase, we actually have 2 Nobel laureates. Most people don't know that. We have a really strong history of science at our institute. And he goes, look, you're not just talking about genomic, heterogeneity. You're talking about epigenomic, metabolomic, proteomic, transcriptomes, kinomic. It's just iterative and iterative. How do you make sense of it all, right? It's really tough. But now you'll see that all this data is coming out about how and what the extent of this intratumoral heterogeneity is. And I'm showing you here kidney. I look for these articles in the literature looking at sort of heterogeneity across all different tumor types. And I say, where's kidney fitting? Where's kidney fitting? How's that informing my understanding of this disease, right? And they all sort of do the same thing. Here it is sort of by copy numbers, right? Gain and loss. And here it is by, the epigenome. And then here it is by, sort of point mutations, NOH. And then here it is by, the transcriptome, and then here it is by the metabolome. It's just sort of in that spectrum, that's sort of where they're talking about heterogeneity. We did this. We've been interested in this. I won't go into it, but we've gone through sort of, the whole methylome of the small renal mass to see if we can understand the epigenetic forces. And we sort of divide it up, and we do canonical modeling like you do. And this talk isn't about the translational research that we do, but this is what's happening. And most of you have seen this paper, right? I don't know if the residents know of this paper, but this is sort of a landmark paper in kidney cancer by Gerlinger, New England Journal of Medicine. What they did is they took one patient and they biopsied multiple sites in his or her kidney tumor and multiple sites in their metastatic, and they did sort of genomic analysis, and they said essentially that Mukherjee is right, that there's lots and lots of different clones, and most of those clones sort of are not shared between the primary and between the metastatic focus. Most of them are, quote, private mutations, not ubiquitous or shared mutations, right? Meaning, of course, to me, that maybe Fisher was right and Halsted was wrong, right? So can we do a better job at this? So they come up with these things, and you'll see these all, right? I think this is fascinating. Somebody's figured this stuff out. The fact that they've thought of it makes me really, inspired, right? So you've got these truncal mutations with VHL and PBRM1, and then some clones go this way, and some clones go that way, and so what have they done now? And we've tried to do this too, right? So we've published on, chromatin loss and, haploinsufficiency and copy number analysis. So we've tried to add something to this idea. We've also done it with mRNA, and I'm not going to go into this, but we've done sort of the same ideas, and we've got our own sort of flavor and mix on this from our scientists. But here's the best study that I could. There's 2 studies that I want to tell you about before I finish on this concept of tumor heterogeneity and Fisher versus Halsted. Anybody read this paper by Bishoy? I'm sure that you have, Peter. This is a great study. This guy's a medical oncologist, at Cornell, actually. And what did he do? He said, I'm going to, in one patient, sample across the evolution of that person's disease, the tumor. All right? So if you see down here, right, TURBT, multiple sites, I'm going to take those, right? Then we give you neoadjuvant chemotherapy. And then the bladder comes out, I'm going to take a bunch of those, right? Then metastatic disease, I'm going to take a bunch of those tumors. And then you die, and I'm going to go in, I'm going to rush in, I'm going to do warm autopsy, I'm going to take a bunch of those, right? And so he did it at multiple sites to see what Mukherjee was talking about, how the tumor evolved genetically, not just de novo, but in response to treatment as well. And this is what he found, right? He found exactly a genetic tree, and he followed the mutations across the spectrum of the disease. Now, I'm going to just show you something right here. I'd like to walk up to this, but this is right here, initially, what the mutations were. And then you've got that pelvic lymph node, right? That had a different mutation, profile, right? You see number 1 where it says pelvic lymph node? What happened to that mutation profile? It died. It went away, right? Why? Because we removed it. They had a lymph node. The lymph node was removed at the time of surgery, and that clone was cured with surgery. You don't see it anywhere else, right? But then if you keep going down, right, you'll see the same thing. Some clones were cured with chemotherapy. And so it was essentially survival of the fittest. Some you pluck out, some you poison out, but in the end, it wins. And those are the clones at the end in green. Those are the ones that they found at autopsy, right? So branched evolution, he concluded, is an early event, that lymph node metastasis can occur in early clones, and it can be surgically eradicated, and that mutations of genes predicting response to platinum disappeared at recurrence. I know which genes, and there's lots of, and Peter knows this, we've published on profiles of specific, genetic profiles, mostly DNA mismatch repair genes, that predict for recurrence or predict for response to platinum-based chemotherapies. And they can be eradicated. But if others persist, you lose, right? So he said chemotherapy-treated urothelial carcinoma is characterized by mutational heterogeneity, and the mutations are mostly not shared. He also said these are early events in bladder cancer. Some patients, the ones we're not curing, have early events, right? So that was the first study that I want to tell you. I'm going to tell you very quickly about a second study, and it's in colon cancer. And these guys and gals in colon cancer, so that he would suggest, of course, that this is a Fisher-esque model of bladder cancer. Right? Now, then you could decide how you're going to deal with that, right? This is in colon cancer. This group is from the MGH. This is what they did in colon cancer. They asked a simple question. Because in colon cancer, I can tell you all the time, you know the conversation we're having in bladder cancer about how many nodes is enough? And in prostate cancer? Well, they've already had that conversation in colon cancer. And they actually have, a quality measure to suggest if you don't get out X nodes, you haven't done a good operation. Maybe we shouldn't even actually pay you, which is crazy, right? But they've got that as a national quality measure, the number of nodes you take out. So the question about nodal extent in colon cancer has been asked, and even though there's a S1011, is Seth Lerner's trial on this, and we're asking it as well, right? The question is, can you cure more bladder cancer with a more extensive nodal dissection? We've asked that. And in this particular paper, here's what they did. They said, when I see colon cancer in the nodes, did it come from the primary? And if I see colon cancer in the lungs, did it come from the nodes or did it come from the primary, right? In other words, did we go primary to nodes, nodes to lung, or was there something else that happened? And they used these indels, insertions and deletions. And what they noticed is, you know what, even in the normal colon, because they sampled normal colon, there's lots and lots of, mutational heterogeneity, suggesting that there's all these mutations constantly occurring. Most of them are meaningless, right? But occasionally, you'll have some that are meaningful. And 65% of the time, they said that the nodes and the metastasis were different, and they came from the different primary clones. 2/3 of the time, they said the node clone wasn't the same as the metastatic clone. And here's what they showed all sorts of profiles, right? So N is normal, P is primary, L is lymph node, and M is metastasis. What that person had, this patient had, a Halstedian progression. The normal went into the primary, and the primary and those clones contributed to distant metastasis. And this person had a Fish-Resk model. There was no relationship between the primary, the nodes, and the metastasis in terms of the indels. All right. So why is this important to us? Because it really speaks of so much of what we do. Right? We treat them all the same. But if we could start to figure out who's surgically more resectable, where is it more meaningful, versus who's surgically less resectable, where is it neoadjuvant therapy, adjuvant therapy, et cetera, right? And the role of lymphadenectomy. We debate this in kidney cancer all the time. Take out one node, take out no nodes, take out 5 nodes. Where's the landing zone, right? I mean, you go to any talk, if I were to come here and if you guys were to have asked me to give a talk on the treatment of advanced kidney cancer, it'd be boring as hell. Because I'll tell you about the 55 different studies that say we don't know what the hell we're doing with nodes, right? Because that's the truth, right? We don't. All right. And finally, adjuvant therapy is at best minimally effective. It's costly. It can bring value. It's not been shown to be effective. So what do we need to do? We need to attack less promiscuous upstream pathways. Maybe the way to do this is immunotherapy, right? Keep trying. So there's now these immunotherapy trials. And so Martin alluded to this. I'm the CTC president, and one of the things that I like is that we do these big trials. So the adjuvant atezolizumab trial, do you guys have that here? Adjuvant, the Emotion 010. Do you guys have an adjuvant kidney cancer trial here? Coming. Well, I hope it comes soon because there's a 664. We're almost up to 300 patients. So that's I think a good trial. Now I could go through the concept of neoadjuvant versus adjuvant or just adjuvant trials, and there's differences between these trials. I'm not going to bore you with the differences between the trials, right? I will say that, who's a junior resident? I have the name of a junior resident. I don't want to call anybody. I've already asked you, huh? Can you call him to? Miles. All right, Miles. If you take, okay. Immunotherapy, right? PD-1, checkpoint inhibitors. We all hear about them all the time, right? Okay. So, what are the side effects of PD-1 inhibitor?
Autoimmune reactions, so pneumonitis, essentially anything.
Okay. So, any sort of inflammatory condition, right? Okay. Why is that important to the operating surgeon in the setting of an adjuvant trial? Why is that important? I'll tell you why, all right? Because it relates to what I told you yesterday. Yesterday, Martin wasn't there and Peter wasn't there, and I talked about process and hospital process, et cetera, and how important process is. I had a patient who had a cystectomy. That person was eligible for an adjuvant immunotherapy trial. That person went to my medical oncologist and was put on the adjuvant immunotherapy trial. Adjuvant atezolizumab versus placebo, right? I sent them there, they got put on the trial, and within 2 months of having an operation, a cystectomy, they had that medication. Okay? About 5 days after they started that medication, and I didn't know they started that medication, I got a phone call from the family. And the family said, he's not feeling well, and he lives like 100 miles away. We brought him to a local hospital. They think he has a PE. All right? He's got a PE, anticoagulation, this and that. He's in the unit on a ventilator. Miles, how do you save the man's life?
I would make sure that I don't see them because it's actually pneumonitis.
It's pneumonitis. You put him on steroids. And they didn't. And he died. Right? And that's sobering. Because if you don't know the side effects, then don't put them on the trial. And if the hospital's processes aren't robust enough to know that the guy's on clinical trial, that's your problem. He came to me for help, and he died on a trial, right? So you got to know it. You got to know it. And I'm not going to go through it, but there's lots of, PD-1 lab abnormalities and what the implications are, et cetera, and when you should have it. I'm going to finish up, these are some of the pneumonitis, colitis, myositis, neurotoxicity, et cetera, all right? So I'll finish up. I've got like 3 more slides. I'll finish up with a couple of quick stories. There's all this data now emerging. How do you predict who's going to respond to immunotherapy? Genetically or immunohistochemically, etc. So I was in the operating room, and I was about to start a case, and Bev, one of the OR nurses, says, "Hey, Dr. Uzzo," and she's been there forever. It's like, "My daughter recently had a publication. She's published." And I said, "That's great, Bev. What did she publish on?" "Oh, I don't know. I don't know," she said. She's smart, and she does some immunology research." And I said, "Well, what's her name? I'll look it up." So I pull up PubMed, and she tells me her name, and her name's Jennifer Uram. I go, "Bev, your daughter's in the New England Journal of Medicine as a second author." She's like, "Oh, is that good?" It's like, "Yeah, Bev, that's real good." All right. So congratulations, that's great. And this is one of the first papers published to look at people who responded to PD-1 inhibitors. And it's based on genetics. And what this group did is they said, we've got patients with colon cancer who have Lynch syndrome and patients with colon cancer who don't have Lynch syndrome. Miles, who's going to respond better? People with Lynch syndrome or people without Lynch syndrome? Just tell me what you would predict. Why? They had DNA mismatch-repair genes. They've got more antigen. And in fact, that's exactly what they found. Great, good. So they had better responses. And that was the first thing. And then, of course, now you start seeing science, et cetera, all these genomic correlates to checkpoint inhibitors. So getting back to the translational science, right? And so that's where this is all going. And in your lifetime, you're going to do a much better job than we've done. All right, so why is this important, right? I'm going to end with a little story. How many people do Facebook? A lot, probably. Not me. But what is Facebook's platform really? Are they a news media organization? They're data. They don't care about it. They feed it to people because it's sort of a platform to take your data and sell it. That's basically what it is. So there's this now evolving question about your genetics, right? Right now there's a big fight, not a fight. It's actually not a fight at all. But right now everybody wants the big genetic databases, right? And so these platforms, 23andMe, Ancestry.com, Veritas, etc., they're going to give you something for your data. And if you do it, you're essentially going to give them the ability to use your genetics and sell it. And that's what they're doing. Flatiron. Anybody hear of Flatiron? It's a big startup company. Just bought a big data sort of genetic company. Just bought for $1.9 billion just 2 weeks ago, right? So if you want, I tell my kids this all the time. You want to go on Facebook because you find it of value, fine. But don't get bothered by the ads. They don't really get bothered by any of that stuff. But essentially what you're doing is every time you put information out there, you're giving them information that they can use. And so that's good. That's the contract, right, between you and Facebook. And that's a contract between 23andMe. All right, so if you think that right now, Foundation Medicine or UBC or whoever has these big biorepositories of this genetic data, and they're trying to sort of monetize them. If you think that can't be done, it can be done, and this is how they're doing it. So I'm going to just show you quickly in the Boston Globe 2 weeks ago. This guy George Church, PhD from Harvard, started a company, and he's going to combine blockchain, cryptocurrency, and genomics, all that stuff sort of put together, right? So what he's trying to say, and I just thought this was a little bit of a nice way to end this, is that the people should control their genetic data. If you want to sell your genetic data, sell your genetic data. I'll give you a token for it. You can trade tokens however you want to do it. Blockchain, I don't know how many of you guys know about blockchain, but if you don't, you should learn about it. Blockchain's really powerful technology, everybody's talking about it. So what happened? So I actually went and I did I did Ancestry.com. My wife gave me a kit. She's like, here, do this, right? So I did it. And I put it right here. Now, I'm Italian 150%. So I told my mom, I was like, Mom, I did Ancestry.com. And she said, what's that? And I go, that's this thing. And in point of fact, I realized it's just a platform for them to use my DNA for something else. And I said, guess what? I'm 100% Sicilian and Italian. She goes, I could have told you that. Right? Not very helpful. I said, yeah, but Mom, now you're going to do it. Because I want to see, right, where you're from. She goes, I know where I'm from. I said, okay. So she does it. And I get like a notice. And this is what the notice says. It says, Mary Uzzo, relationship. Mary Ann Uzzo is your mother. Based on genetics. So I call her up and said, Mom, good news. It's like, you're my mom. And she goes, I could have told you that too. I said, yeah, but you couldn't tell me this. I had my son do it. I said, they're extremely confident he's actually my son. So it's just kind of fun, right? So genomics is out there, it's kind of fun. But the idea behind it is powerful, right? We make fundamental decisions on poor predictive tools. We spend billions of dollars on negative adjuvant trials. Heterogeneity makes a single home run in adjuvant therapy less likely. Understanding what we don't know versus what we do know helps us to make better decisions. I'd like to thank you guys for the invitation. And I want to ask you have one last slide. I had a patient, total Philadelphia story, totally true. I did a partial nephrectomy and a solitary kidney, and the guy had a tumor thrombus. And he's like, 5 people said, kidney's got to come out, kidney's got to come out. I said, no, we can fix this. We can fix this problem. And he said at the end, he's like, Doc, I'm so thankful. Of course, I had to have this adjuvant trial, talk about it. Do you want to go on? The models and statistics and UISS and crap. And he's like, you know what, Doc? I'll do whatever you say. Because here's what I think about kidney cancer. And he lifted his shirt like this. And this is what he said. Thank you very much.